Yes, sir. We are.
Yes, Dr. Ghosh, we can start, sir.
Yeah. Good evening. Welcome to this scientific session titled Conquering Menace of Post-BMT Viral Infection. Today, my name is Dr. Ankush Gaikwad. I lead the medical oncology at Emcure. At the outset, I would like to extend a warm welcome to all our esteemed faculty to this virtual meeting. Management of infections is a crucial part post bone marrow transplant. Here in this webinar today, we will be discussing on optimal management of viral infections post bone marrow transplant. In today's session, we will have an expert lecture on conquering menace of post BMT viral infections, followed by a rich panel discussion with our esteemed experts. To start this session, I'm very pleased. It's my honor and pleasure to introduce our first expert speaker and chairperson for today, Dr. Shashikant Apte sir. Sir is a senior consultant hematology and bone marrow transplant at Sahyadri Hospitals, Pune. Sir, I hand over to you for your opening remarks and your talk for this scientific session today.
Thank you, Dr. Ankush. If you can stop sharing, I'll share my screen.
Yes, sir.
So I thank Dr. Ankush, Yogesh, and Team Emcure for organizing this webinar and asking me to speak on this important topic. A lot of transplanters are young. They're working in the field for less than 5-10 years. They won't know how it was to work and do allogenic or autologous transplant when there was no viral monitoring. And we have gone through that stage, and it was always a nightmare to see enzymes rising, bilirubin rising, and we had no clue whether it is CMV related. Drugs were not available. But the scene has definitely changed, and we are able to treat these diseases better and tackle these complications in a better way. All these things, all the infections are dependent on what kind of immune surveillance, immune system we have when we take a person for transplant. There could be a pre-transplant phase like acute leukemias, lymphomas. They would have undergone quite a heavy pre-transplant chemotherapy, and that would complicate the viral infections even pre-transplant. Whereas you go to the other areas of transplantation where the treatment is less, especially aplastics, you will have less chance of viral infections pre-transplant. Once the engraftment occurs, slowly the neutropenia recovers first, then the NK cells come out first, and then the T cell and B cell recovery happens. And while this post-engraftment happens, the other phenomena that occurs is acute and chronic graft versus host disease, which compounds the risk of these viral infections. These are the viral infections and types of infection known when we are doing allogenic or autologous transplant. Autologous transplant, the viral infections are less, but they are not zero. Rarely we have seen a CMV reactivation, CMV disease in autologous stem cell transplant, and we have to keep vigilance even in autologous transplant. The neutropenia part is the main thing in autologous transplant. There is no immune change, or there is no graft versus host disease, or there is no intense immunosuppression post-transplant in autologous transplant. CMV, EBV, VZV, and HSV are one of the common viruses that we see, and also the BK virus. BK virus hemorrhagic cystitis is all transplanters would agree is a nightmare to treat it, and we have to pull out these patients quite aggressively. This is the incidence of infection in allogenic and autologous stem cell transplant. The viral infections have the highest in allogenic transplant, followed by bacterial and fungal. I must really compliment that the microbiology support in the country over last 10-15 years and the therapeutic support coming from the pharma has really increased our armamentarium. We have so many antivirals, we have so many antifungals. Treating these infections and taking patients to complicated allogenic transplants has become less difficult. I won't say that it has become easy, but I would say that it has become less difficult. And these are the viral infections that we anticipate post stem cell transplant. And these are the latent infections, these are more important. CMV tops the list, and CMV viremia, CMV disease can be one of the major causes of morbidity and mortality in post HSCT setting. Whereas rarely we do see these sporadic infections, adenovirus, parainfluenza, and RSV, and not to forget now the COVID virus. SARS-CoV group of viruses have really hit us over the last 3-4 years. But luckily, now we are not seeing such an intense or very aggressive COVID form in the form of infection in normal population as well as in immunocompromised. These are the standard indications that we see. And depending on the indication, as I explained in my previous slide, one can have a immune suppressed state prior to the transplant. Among the post-viral infections, CMV, BK, and adenovirus would take the top. CMV infections in HSCT, there is a very high seroprevalence in developing world. More than 98% of Indian population is CMV positive and exposed to CMV with CMV IgG in higher range. We have done more than 850 transplants over the last 24-25 years. And only one pair we had that it was CMV negative, both donor as well as a recipient. We can have 4 combinations, CMV as far as the CMV status goes. The worst combination is recipient positive and donor negative. Because if the donor is negative and recipient is positive, we are going to run into much trouble because the lymphocytes from the donor have never seen the CMV virus. And we are going to have a lot of complications, CMV viremia, post transplant with this combination. And this is a real problem in Western world because the seroprevalence of CMV in Western world is around 50%. So 50% of your population is going to be CMV negative. It is important to identify the high-risk populations. Haplotransplants are definitely rising. In our country, haplotransplant have really boomed, and even in the world, and haplotransplant and T-cell dysfunction among the patients who are receiving ATG, the patients who get graft versus host disease receive severe immunosuppression, and these are the groups that they are the risk population, high-risk population for CMV reactivation or CMV disease. To summarize, we have haplo-STT grade 2 to 4 GVH as a risk factor, T-cell depleted STTs and antithymocyte globulin compound the issue, and CMV reactivation or any viral reactivation is very high. And high-dose steroids that when we use for the treatment of GVH complicates and contributes to the risk of viral activation. When we are taking a decision, we have to consider certain aspects. We have to keep in mind, did any CMV prophylaxis was given prior to the transplant and for how long? Did high level of CMV reactivation occur during or following antiviral prophylaxis? If that has been documented, then it is better to indicate and screen the patient for antiviral resistance. Is the patient at high risk of CMV disease, as I said in cord transplant, haplo-STTs, seroprophylaxis, graft versus host disease from unrelated donors? And we have to understand the CMV load and kinetics. There is a CMV specific T-cell reconstitution, and this CMV specific T-cell reconstitution also can be used as a therapeutic modality. And pre-transplant comorbidities worsen the CMV reactivation, BK virus reactivation, and complications post-transplant. These are the CMV monitoring schedules that have been recommended. We are doing in our center once the engraftment occurs, at least a week till day 90 post-transplant. Once post-transplant situation, day 90 has reached and the T-cell reactivation has happened, we start monitoring once in 15 days. Some people are recommending, especially in haplotransplant or T-cell deplete transplant, to monitor viruses twice a week. Once we do that, we have to keep in mind the cost involved in doing the RQ-PCR. When we come to the point of CMV prevention, the CMV prophylactic therapy is given in CMV seropositive patients. In our institute, our policy is to give CMV prophylaxis with ganciclovir pre-transplant from day -9 to day -2. It has shown a definite decrease in CMV disease, but no specific difference if the patient gets CMV disease in mortality. Prophylaxis with antivirals have to be carefully used as it also can cause cytopenias. Then we give preemptive therapy. The preemptive treatment approach involves screening the viral load by PCR weekly and initiating antivirals on documenting the viremia. And these are the situations where this is the data from Letomobile study that they had done, but everybody is doing the similar algorithms even with non-Letomobile era. So preemptive treatment threshold, ganciclovir is the most commonly used antiviral drug for CMV preemptive therapy. Preemptive therapy is given when there is a increase in viral load. Already the pharmacokinetic studies have shown that oral valganciclovir can achieve the comparable results with the higher drug exposure. Our own experience in our own center has been very poor, and we have gone back to intravenous ganciclovir whenever we have used ganciclovir in preemptive mode or prophylactic. Cidofovir in recommendation is the third-line CMV preemptive therapy. I cannot share the data because we are preparing this paper for ASH. But last 3 years, we are using cidofovir as a prophylaxis in haplotransplant MUDs and allos. After viral activation has happened, and even if there is no viremia, we are giving 2.5 milligram kg of once a week cidofovir, and we have now 72 patients from haplo and MUD group with very significant data, but because of the ASH rules, I cannot submit that or show that data here. And we are quite happy that our usage of therapeutic dose of ganciclovir or foscarnet has definitely come down after we have switched over to this cidofovir prophylaxis. Treatment of CMV disease, the drug of choice is always ganciclovir. Whenever in our situation or institute also, when the patient is on cidofovir prophylaxis, starts getting viremia, we stop cidofovir and go back to ganciclovir at 5 milligram per kg twice a day. But it creates a problem because ganciclovir is known to cause cytopenias. We have to check the issue of ganciclovir resistance when we are already giving ganciclovir and the copy numbers don't come down. And then we go to cidofovir in a therapeutic dose. There are 2 phase 2 trials of maribavir now available to have show efficacy as preemptive therapy and treatment of CMV infections. Maribavir is indicated in treatments of adult and pediatric patients weighing at least 35 kg in post-transplant CMV infection or disease, where there has been a resistance to ganciclovir, valganciclovir, cidofovir, or foscarnet. Adaptive T-cell therapy is an emerging option for treatment of refractory and resistant CMV, and Dr. David Gottlieb's group from Westmead has done really interesting work in this area. There are different CMV vaccine trials, but except for Peprax, no trial has shown promising results in phase 1 trial. Antiviral resistance is definitely becoming a menace in our population, and persistent viral load or either with viral load becomes elevated more than tenfold over the therapeutic treatment range. And the rapid deterioration of symptoms after appropriate treatment for more than 2 weeks is one of the basic suspicions to suspect antiviral resistance. There is enough data of CMV in pediatric patients. There is a data from India as well. And seropositive status in that study in India was 88%. And CMV infection was seen in 66% and CMV disease in 8.5%. Another virus is BK virus. I won't go into the great details, but primary infection and tropism is well known. Hemorrhagic cystitis really worsens with BK virus activation. Generally, now we are using more post-transplant cyclophosphamide, and there is quite a heavy exposure to cyclophosphamide, which is a risk factor for BK virus activation and BK virus tropism and BK virus cystitis. BK viremia occurs in about 50% of the patients after BMT, usually within first 2 months of the transplantation. The incidence of BK viremia is similar in allogenic and autologous transplant, but really the issue arises when there is an associated hemorrhagic cystitis. And it is very important to treat BK virus aggressively, otherwise you can have an uncontrolled hemorrhagic cystitis, and it is again a nightmare situation to manage. So there are approaches to manage post-BMT viral infections. There is a prophylaxis. These 4 drugs are very routinely used. Letermovir is not available in our country. Preemptively, we are using ganciclovir and cidofovir, and therapeutically, we are using ganciclovir, cidofovir, and foscarnet. We have used foscarnet only in 2 situations where the patient had not responded to ganciclovir and cidofovir, and empirically we use. But whenever we have used foscarnet, we have generally lost the patients. So cidofovir is an antiviral nucleotide drug. It has got a great action against the CMV and other herpes viruses. And most importantly, cidofovir is not phosphorylated and hence does not be inactivated by viral kinase. Cidofovir spectrum already I have discussed. It has been used widely in all the viral infection post-transplant, CMV, HSV, BK, VZV. But against cidofovir, usage in prophylactic way can be an interesting situation in our country. And I strongly suggest that we have a multi-center data collection at least, whether cidofovir prophylaxis helps to reduce CMV viremia and CMV disease. So CMV cidofovir reactivation is quite an ordeal. It nearly takes totally 12 to 16 hours, but this is the way to, and it is done to protect the kidneys when we are giving cidofovir. We have to make sure that certain drugs are stopped before we give cidofovir infusion. And this is the data of cidofovir in cytomegalovirus infection and CMV disease. And it has shown an excellent results, especially when there is a ganciclovir resistance. There are another few studies. And this is the algorithm when we do the CMV monitoring and study the CMV resistance and change of the drugs while doing the therapy. This was the recent paper, cidofovir as a choice of salvage treatment in haploidentical transplants. It is becoming a great area even in our country as haplotransplants are rising in our own Indian setting. So with that, I would thank my, I will end my talk. We'll have some discussion. And again, thank Dr. Ankush, Yogesh and his Emcure team for organizing this webinar and giving me this chance to speak in front of this crowd. Thank you all.
Thank you so much, sir, for your thank you so much, sir, for your enlightening talk. I think we look forward to your data at ASH, and I'm sure that it will be some of the data which will also change the practice in the treatment of viral infections post BMT. I'll share my screen. So to move on the next part in our webinar today, scientific session today, I am pleased to invite Dr. Sameer Melinkari, sir. So he's the HOD and Director of Bone Marrow Transplant Unit at Dinanath Mangeshkar Hospital, Pune. And so we'll be moderating session on post-BMT viral infections. I'll also have a pleasure to introduce our expert panelist for today, Dr. Shantanu Hussain. So he's a Senior Consultant Head of Pediatric Hematology Oncology at Kokilabehn Ambani Hospital. Dr. Chintan Vyas, sir is a pediatric hematologist oncologist at SRCC Children's Hospital, Mumbai, and Dr. Neha Rastogi Panda ma'am. Ma'am is a senior infectious disease specialist at Fortis Memorial Research Institute, Gurgaon. So over to you, sir, for your moderation for today. We'll stop sharing my screen.
I'll share my screen. 1 second. I hope this is visible.
Yes, sir, visible.
Okay. So I welcome all the participants, the panelists. Neha is an ID specialist, so it's good to have her here. And then, of course, we have Shantanu, Chintan, and Balkrishna is not there, I think. Is he there?
No, sir.
Okay, fine. So we'll start off with uh, Shantanu, and maybe you can tell us what are the major viruses that you would be worried about post-transplant, and how would you assess? How do you assess? I mean, post-transplant, how do you assess and monitor viral infections in HSCT recipients?
All right. Can you guys hear me? Sorry, I'm traveling in a car, so there will be a lot of traffic noise. So I apologize for that.
No problem.
Okay.
It's quite
So,
loud and clear.
all right, great. So if I talk about post-transplant viral infections and in tune with what Shashi has just said, the one virus we are worried about most remains CMV. So what we do is, of course, kind of like standard workup that we do for transplants, that before we take the patient for a transplant, we check the patient and the donor's CMV status. And of course, as Sashi mentioned, the worst nightmare is that if you have a patient who is seropositive and your donor is seronegative. Now, Shashi mentioned that that's a big problem in the Western world. But to be honest, we are seeing this in India as well. And I have had at least about 3 patients, and I've got another something like 4 or 5 patients in the pipeline who are the same situation. And these are the patients. What happens is you do a transplant, and post-transplant, because the donor cells has not been exposed to the virus at all, they get rip-roaring CMV infection. How do we monitor? So post-transplant, we actually do CMV viral load twice a week on Tuesdays and Thursdays, Mondays and Thursdays, and we check the CMV viral load for all of the patient. Now, we monitor and we practice as a basis a CMV preemptive strategy. We look at the CMV viral load, and if the viral load crosses 1000, which has been our traditional watermark at which we react, then we would treat. Now, so that's so assessment, that's for CMV. We also, if you're worried, we actually do a triple virus panel, which is looking at CMV, EBV, and adeno together in one test. And that usually we don't run for all, but when we're worried about other infections, that's when we actually run that panel. BK virus, we don't monitor as a routine, but if we find that a patient's having hemorrhagic cystitis, that's when we do it. And again, with BK, it's mainly that if we have a high viral load, plus we have hematuria, that's when we know that we'll be entering into troublesome territory.
Thanks. Thanks for this, concise answer. Chintan, if you have anything else different to add, I mean, if your monitoring strategy is different, you could mention it.
No, I think more or less I agree with Dr. Shantanu. Yeah, we used to monitor sometimes when in immunodeficiency patients which we are dealing with or having a previous history of CMV infections. In those cases, we start monitoring from post-transplant immediately, because sometimes we see an early viral reactivation and sometimes it is very surprising. So those things, but yeah, usually in general, my practice, I start from day +7 or day +14, depends on the engraftment and whether I'm dealing with haplo T cell deplete versus T cell replete. Yeah. But immunodeficiency child, I usually start from the day of conditioning.
Okay. So in our
just saying that usually, which is a bit true, that your CMV infection comes on kind of peri-engraftment, but we have kind of learned to our chagrin that that will not always be correct. And we do have some patients, especially it also depends upon it depends on a lot of factors. It depends upon your patient has CMV before. It depends what kind of conditioning you've used and the kind of worst things that you can get. I mean, things that you have that if you're using ATG, especially if you're using alemtuzumab, which really, really knocks out your T cell population completely, and things like PTCy in your haplo, cyclophosphamide is a very, very lymphodepletive agent. So with those kind of agents in your conditioning, if you have used, you can get very early CMV reactivation in those cases. So that's how we've changed actually. Say, okay, immediately, I mean, even after day 0, we just start, okay, let's start looking at it. And if we find it, then of course we are in the troublesome situation. And I'm sure we'll discuss that later as we go on as to what do we do and how we treat with early CMV reactivation that happens before you have stem cell engraftment.
Sure. Yeah. So we do the same, just that we when it's haplotransplant, we monitor the adeno EBV and CMV combo panel. We do it in-house and we do it every other week. That's bi-weekly. And CMV we check weekly. Actually, we don't check twice a week. We check it weekly. But for match sibling donor transplants, we check only predominantly CMV, and the others we look only if we feel the need is there. So timing of viral infections, I think we're all aware of this. Predominantly, we just discussed all this, so I won't go through this much in detail. I'll go to the next slide. So CMV, predominantly a problem of haploidentical transplants. Of course, in haploidentical transplants, our data is that probably we see more than 90% of our patients having CMV reactivation. And the more the T cell depletion, you'll have more chances of CMV infection with GVHD, etc. You're going to have high chances of CMV infection. Adenovirus is common in haplo and T cell deplete grafts or unrelated donor transplants. Especially when you have GVHD, younger patients will in general have a higher chance of CMV or any viral reactivation as compared to adults. And then BK virus. So it's important to note that almost 80% of your patients are going to show BK virus shedding in your urine. So if it's asymptomatic, we generally wouldn't treat. So maybe Neha, can you just tell us when you actually monitor for BK virus? When you do it in the urine, when you check it in the blood?
So yeah, sir. So in heart center, we usually don't, as you have already mentioned, we don't usually look for BK virus upfront. So most of the times when you are having the cystitis-like symptoms, we first go with the urine routine, which is one of the basic. You can have a microscopic hematuria detected at the first place. Since in Indian settings, UTI per se from the bacterial and other infections are still common, I would say more than BK. So we correspondingly screen for routine cultures, and for the BK, then we monitor. In terms of their treatment strategy, usually BK, all the cidofovir, Ciplox, honestly speaking, Abhi, the recent guidelines have even come up in, though they are in SOT, but to just extrapolate in even HSCT, usually there is no standard guidelines for the treatment of BK and none majorly works as well. So if there is a grade 2 to grade 3 hemorrhagic cystitis proven on the USG KUB, there is a persistent hematuria barring reduction in immunosuppression, keeping even the platelet count above 50,000. There we introduce cidofovir, but that's very conditional cases.
Immunoglobulins, any use?
So usually the
IVIG?
IVIG is a very, again, the limited practice in BK
Sure.
as well. Yeah.
Sure. Thank you. Then we concern about HSV infection, and that can happen even during the neutropenic period. So that's important to monitor. But generally, we're giving acyclovir prophylaxis, so this is less common. And VZV infection, again, is common, and that can happen up to several months post transplant. EBV generally occurs late post engraftment. It occurs due to that we all know sort of what the mechanism of EBV infection is, so I won't discuss that. And HHV6 something is it's a very important virus because it's the more commonest virus causing encephalitis in patients post transplant. Okay, so coming to approaches to management of post-BMT viral infections, letermovir is going to be available. It's round the corner. We don't know when it will come, but very soon, most likely this year, and that will completely change the whole scene. I hope the incidence of CMV reactivation would be significantly decreased when you use letter mover as prophylaxis. It's not very useful when you use it as treatment for resistant CMV infection, but for prophylaxis, definitely it's going to be the best strategy. And all the others are dry, and it was interesting to see Dr. Apte's. We haven't, I don't know the data, but when it's published, it will be great to look at it. Uh, I'm not sure how much we would be using Cidofovir when letter mover becomes available, but it's something which we can really look at. Preemptively, we use ganciclovir, valganciclovir, foscarnet, and cidofovir, and therapeutic we use ganciclovir, foscarnet, and cidofovir. So let's start with Shantanu again. How do you approach post? How are you using? What are you using as prophylaxis for your post BMT viral infection? Any specific drugs? Say for CMV. Shantanu. Okay, maybe Chintan.
Can you hear me? Sorry, can you hear me?
Yeah.
My laptop switched off, so I've switched over to a mobile. Sorry.
Okay.
So I'm saying that I think I joined with most of my transplanters in saying that if we look at which is our primary prophylaxis for post BMT viral infections, it remains acyclovir. But as we all know, acyclovir will not be effective against CMV. So in that case, so in which case for prophylaxis for CMV, it only comes in when we know that we are going to have a problem with CMV, which is when we talked about the donor recipient mismatches or haplo, we don't usually do it, but certainly when we have a donor recipient, when your donor is seronegative and your recipient is seropositive, that's when we actually go in for proper prophylaxis. And we do something very similar to what Shashi had said, which is we would be giving ganciclovir before the conditioning, starting from day -9, day -10 up to day -2. We try to do at least for a week so that we start at least from day -9 and finish the ganciclovir at day -2. After that, usually we just do preemptive treatment where we monitor. But if we know that the patient it's going to come, that's when we started using, much like Shashi, we using cidofovir. But we don't do it automatically. But the minute our CMV viral load starts to go up, even if it's been negative and it's gone up to something like 200 or 300, we would take that as our sign for us to actively start treating. At that point of time, if we use ganciclovir or even Valgan, it's the same drug basically, we would almost inevitably lose the graft because ganciclovir is a myelosuppressive, myelotoxic agent, and it kills the stem cells. And it's between the devil and the deep blue sea, because you are cursed if you don't treat it, and if you treat it with ganciclovir, will kill it. If you don't treat it, CMV will kill the graft. And it has happened to us as well. We burned our fingers. So in this case, we actually start off with cidofovir straight away. And to be honest, we are also actually getting our data together, and we've had good experience of using cidofovir before engraftment, and we've managed to pull quite a few of our patients up to engraftment and beyond. And therapeutic, once we are post engraftment, we are at day 15, day 20, we know we've got a good graft there, and we haven't managed to control the CMV with cidofovir, and that does happen in some cases. Then we switch to ganciclovir almost instantaneously and say that, okay, that's what we need to treat.
Chintan, what is the CMV level at which you would decide to treat? Would it be different for different types of transplants, like in haplo versus match sibling, and also for
Yeah.
adenovirus?
So for the CMV or adeno, I usually treat anything more than 500. So it doesn't really change. I definitely, for my match sibling donor, I sometimes, if it is just 300 or 400, I may double check 4-5 days later and just then. But for haplo, no wait, start away treatment straight away, preemptive treatment. As Dr. Shantanu has said, that any level is significant, so you don't have to have that cutoff. Although people say that 1000 is an ideal cutoff, but sometimes in an haplo setting where you may have GVHD any time and you don't have to wait for 5 days when you will become 500 to 1500. So you don't have to wait too much. Then about the adenovirus also, it is same, but the adenovirus slightly is different. The adenovirus, I keep it more than 1,000 copies, but usually we don't see adenovirus. We usually check in our all haplo patients. So our incidence of adenoviremia is still not that very high. But yeah, if it is more than 1,000, definitely we start treating. And then important thing about that, the slightly different, approach in which I usually do sometimes in my T cell deplete haplotransplant. When I do the T cell deplete haplotransplant and I know that my patient is having viral reactivation, I start giving memory cells also, which I have collected in the stem cell graft. So that is just an additional thing which I try to do, and I supplement them with IVIG, particularly in haplotransplant, whether they are T cell replete or T cell deplete at the time of viral reactivation. Letermovir I have used in prophylaxis, not in therapeutic, and so I would like to recommend that whenever we used to suggest the letermovir may change the cidofovir, I am still a bit skeptical that letermovir will be used as a therapeutic option and not just as a prophylaxis. So that is still the data yet to come. So the letermovir for prophylaxis, yes, it's an approved indication, but for therapeutic, it is still not there yet. I have used Foscarnet also in pre-transplant, pre-engraftment period, but the cost is a significant barrier. So I reserve ganciclovir as a first line post-engraftment, cidofovir as a first line pre-engraftment. And after 2 weeks, if the load, a CM load is not getting down, or if you are having any kind of CMV disease or adenovirus disease, I quickly switch to cidofovir rather than waiting for a few more weeks. So after 2 weeks, if it does not helping, I either switch to cidofovir or add on to artesunate, something like that.
Yeah, I'm just going to say two more things to add on to that. I agree with you. I mean, yes, adeno, we haven't really had much issues with it. And even though we monitor in kind of close to, I don't know, 350 odd transplants, we had an adeno issue only in one transplant so far. We've used letermovir prophylaxis in a couple of our patients. I mean, yes, at the moment it's very expensive, and I'm looking forward to when it will become easily available. We've used Foscarnet as well. Nephrotoxicity is a huge issue. You really need to balance that. And again, uh, if we don't have a choice, we after use Foscarnet, we have used it. But I agree completely with what you're saying. Those are the main. Uh, Artesunate, we've used it. I've never been convinced that it's been useful in CMV. And I think Tata has used some other novel agents which they swear by. So I would not like to comment on them without the people who used it being there.
Okay, so Neha, do you have any other comments on? Can you tell us the correct way of managing of handling of how to manage an adenovirus? Do you think it's also very rare? And any other comments on what Shantanu or Chintan have said?
So just to point out, sir, as they have already mentioned, both the sirs, so prophylaxis, even we have procured for the letermovir for 6 of our patients. As they have clearly mentioned, the match siblings still 500, 800 copy numbers still considered as the blips. And then we would like to monitor even after 3 days kinetics and that. But in mud and haplo at any count, prefer to start using it, which we have also used. Letermovir, we have actually reserved for few patients where the D plus R minus status have been there. Since already in the previous question, they have mentioned that, and I also agree to the point that it's not that uncommon in even our settings. However, we have only measured it up to 45 days because of course for the accessibility and cost issues. And that 30 to 45 days till the 45 days is a major time where the reactivation occurs. As far as the adeno is considered, I mean, two way I can approach this. One possibility is, of course, since we don't look very, very oftenly for that virus, because whenever we pick it up, there has been some copy numbers being picked up, but we only picked up in the syndromes management. For example, with the nephritis, For example, with the fever and cytopenias persistent despite the CMV negative, then we try to look for the other viruses, or the fever bar no fever with gastritis and cytopenia. So these are the syndromes which make us think about the adenovirus. So we usually don't upfront look for it in most of the viruses, the transplants. But yeah, in the mud or haplo settings, we do see the adeno screen for adeno and EBV every bi-weekly. I mean, 15 days, sorry. Yeah.
Yeah, so I actually have a different take on the adenovirus. I think we've seen it in a reasonably good number of patients, and in fact, we've had 2 deaths because of adenovirus in haploidentical transplants. And it's important that if you don't recognize it and you don't give cidofovir immediately in a patient who's got symptomatic adenoviral infection, the mortality is close to 100%. So I mean, I think it's important, at least in the haplos, to keep monitoring at least biweekly until day 100, and make sure that you don't miss out on any adenovirus.
I'll agree with you, Samir, completely on that. So we've also started doing the same triple viral PCR that you mentioned, and we are picking up. It's kind of like when you're worried about it, that's when you have to look for.
Yeah,
I mean, I think it's better to look for it before rather than doing it afterwards.
sure. What is your take on valganciclovir and the limitations of ganciclovir in the management of CME infections? We can start with Shantanu.
Uh, I mean, if you're treating it, it remains the drug of choice, to be honest. I mean, the advantage of Valgan, of course, is being it's an oral agent, but regarding efficacy, I think both are equal. My main worry, I mean, as I mentioned with ganciclovir, is basically the myelosuppression. So, yeah, and it causes neutropenia, almost inevitably. So, if you are kind of if you're forced to use it a little bit early post-transplant when engraftment hasn't quite happened, or even if it's happened, it's not quite robust yet, it's very early days, we run a risk of graft failure. And I think many of us transplanters have burnt our fingers on it. So in that case, it becomes a little bit difficult to use. And certainly in cases like this, if we can turn to something that's not inherently myelotoxic, it will be better. So then our choices are at the moment cidofovir plus minus. We can also think of foscarnet in this situation to get us out of it till our cells have engrafted. And once it's engrafted and we are sure, then to be honest, ganciclovir will still remain my drug of choice to treat it.
Sure.
And of course, we can run for 2 weeks. Sorry, yeah.
Yeah. So, Neha, could you tell us in which type of viral infections you would consider cidofovir as a first-line treatment option? I mean, would it be fair to say that in a patient who's got CMV infection and who's got cytopenia, you would prefer to use cidofovir as your first line rather than ganciclovir in view of what Shantanu just said?
So also depends upon, sir, multiple other factors, I would say. If there is
Assuming
a
that foscarnet is
Yeah.
not available and there are a lot of cost constraints and it's not not very easy to procure immediately when you need it, and so is letermovir is very very expensive right now. So at the moment between cidofovir and ganciclovir, what would you use
So
for
again, if there is
adenovirus and others?
no
Yeah,
organ, and so if you are asking only in terms of CMV, sir, for the moment, so if there
yeah,
is no organ involvement as such, there is just viremia. In fact, we have actually used cidofovir as a first-line preemptive therapy in 48 of our patients. We have a data
okay,
which I presented also, but there we have found out that out of those, almost from those 28, I mean the 48 patients, majority of them, 41 patients have actually cleared the viruses. But those typical 7 patients who have actually developed the breakthrough are the ones who has a median viral load of more than 40,000. So this is kind of a strategy which we have seen in those observations, that if we have a viral load which is somewhere above 30,000 to 35,000 because of its kinetic, usually the effect decreases because there are quite a log studies which are available for cidofovir in terms of their PK/PD. Second thing is, if there is still no other option available, then of course with the catch of, I mean the pinch of salt, we will prefer to switch to cidofovir as first line if no other option being available. Connect the talking about the second question which you asked for as a first line upfront, definitely adenovirus we have discussed all, and that remains still the first drug of choice. If there is any option where we have to treat the BK virus, as we were discussing previously, where you have a grade 3 hemorrhagic cystitis going along, cidofovir remains a drug of choice. And suppose if we land up in a situation which is still common also, that when you have two concomitant viral etiologies playing together and both are significant to consider upon, their pseudofovir can also be tried.
Sure. So actually, we're falling short of time, so I'll just quickly go through some of these slides, and just to mention that I don't have time to discuss this, but as when we're looking at a resistant CMV infection, if you have ganciclovir resistance, then on the UL54 gene, the sites where the mutations take place often confer resistance to both ganciclovir and cidofovir together. So if you think that the patient is resistant to ganciclovir and we documented that, it is no point in using cidofovir empirically unless you know exactly which mutation it is. You would then prefer to use foscarnet. But the problem in India is that most of this test is not very easily available. I'm not satisfied with any of the labs so far, and maybe I can take if we have some time later on. We can discuss this issue. Okay, we won't discuss this either. How do you manage risk of nephrotoxicity with cidofovir? And I'll just quickly answer that we need to give probenecid. We all know this infusion, the hydration that you need to give pre and post cidofovir, and the probenecid, which often comes along with the cidofovir. Now, in our patients with BK viral hemorrhagic cystitis, we have used intravesical cidofovir. There's a protocol for this. We use probenecid 2 grams 3 hours prior, and then 5 milligram per kg of cidofovir in 100 ml NS is instilled in the bladder and clamped for 1 to 2 hours if possible, or as long as we can hold it with painkillers, etc. We try and hold it retained as much as possible, and then we release the clinic. And we have used this with some amount of success, although I won't say it's a fantastic technique. Okay, and what are the clinical advantages in the use of cidofovir? And if you can share the results, I think you've already answered this, Shantanu, as well as Dr. Apte, and Neha has also mentioned that in about almost 42 patients, they've used cidofovir as first line. So that will be good, and maybe we can discuss this in the next session. These are just 2 articles about successful treatment of BK virus hemorrhagic cystitis post allogeneic transplant with low dose cidofovir. This is again from India, and another one again. So there are just case reports where the cidofovir has proven to be of some use in very severe BK viral hemorrhagic cystitis. So with that, I thank you all.
Thank you very much, sir, for your for moderating this panel discussion, and to all our esteemed panelists for giving insights. Meanwhile, I'll see if we have any questions from audience, and meanwhile, I would request Dr. Apte sir to kindly give us some of the key takeaways from the audience, which we can give as a takeaway from this lecture to our audience who is present in this webinar, and your opinion on this, on the post-viral BMT infection treatment.
So first thing I would say that whenever we are planning an allogenic transplant, whether it is MRD, MUD or haplo, make sure that you have access to do these viral tests. Because if you don't monitor them, and monitoring has to be very vigilant, at least up to first 100 days. If there is a clinical suspicion, as Dr. Samir Melinkari said, that adenovirus we should suspect, and we should test for adenovirus infection rather than delaying or beating around the bush. As Shantanu said, for therapy, still ganciclovir would remain the first line of therapy even in our center. Our own experience with valganciclovir has been poor, and that's why we are still using IV ganciclovir. But cidofovir definitely would emerge out as a prophylactic drug in the setting of high-risk allogenic transplant. I think that would be my summary for this talk.
Thank you, sir, for summarizing this talk, both your session and the panel discussion. I see no questions from audience right now. So I would like to thank all our faculty for this scientific session today. Special thanks to Dr. Shashikant Apte sir for taking a session on this topic, and to Dr. Samir Melinkari sir for moderating a wonderful panel discussion, and to our panelists, Dr. Shantanu Sen sir, Dr. Chintan Vyas sir, and Dr. Neha ma'am for contributing their valuable insights. And also, I would like to thank all our delegates who have attended this webinar for their patient hearing and I hope that this was significantly important for you and as contribution for treating these infections in the post BMT setting. So thank you once again and have a good night. Thank you.
Thank you. Good night. Good night, everyone.
Good night. Thank you.
Thank you,
Thank
sir.
you so much. Thank you. Thank you for asking me to be part of this. Thank you.
Thank you.
Thank you very much, sir.
Thank you, Ankush.
Thank you, sir. Bye bye,
Thank you.
sir. Good night.
Should I end this meeting?
Yes.
Okay.